I'm Dr. Christopher Schneck. I am a professor of psychiatry. I'm the medical director of the Helen and Arthur E. Johnson Depression Center and also the medical director of the CU Medicine Bipolar Clinic. The topic for this video is treatment overview, medications. Bipolar disorder, while a serious illness, is a treatable illness. And in study after study, we find that people with bipolar disorder do best when incorporating these four elements into their individual treatment: medications, psychotherapy, self-management techniques, and support from family, friends, and community. We have other videos that go much more in depth in the psychotherapy, self-management techniques, and support areas, and this video will focus on medications. We firmly believe that the more you understand about bipolar disorder and its treatment, the better you will do. One of the difficulties in treating bipolar disorder is that in many ways it's not a single illness, but a combination of three different mood states. Patients can become manic, and therefore medications must be able to treat mania. Patients can become depressed, and therefore medications need to treat the acute phase of depression. And then once a mood becomes stabilized, medications must be able to continue the stable mood as well as prevent future episodes. In thinking about an overview on the treatment process for bipolar disorder, when meeting with a provider, patients most often will review current symptoms, stresses, and situations that are affecting well-being, mental health, and physical health. The goal will be to assess how well treatment is currently working and then making adjustments to your treatment as needed, whether that's in medications or psychosocial treatments, adjusting medications to optimize treatment effect and minimize any side effect, and finally to assess and suggest other strategies to help manage stress, coping with stress, sleep, and activities. Let's talk more specifically around medication treatment. Treatment of bipolar disorder aims to reduce the severity and frequency of mood episodes, and studies have shown that medications clearly reduce the frequency and severity of manias and depressions. Medications are considered first-line treatment for bipolar disorder. Finding the right medication or combination of medications can take time and requires you to work with your provider to fine-tune the medications, which really means maximizing treatment effect and minimizing side effects. Different medications in your regimen will make more sense when you understand what class of drugs they belong to and what their specific purpose is. For example, helping with mood, helping with sleep, or helping with anxiety. So what should medications do for you? Well, they should control and help resolve an episode that has already developed. They should delay future episodes and minimize the severity of those that do occur. They should reduce the severity of symptoms you may experience between episodes. And finally, medications should give you minimal side effects or ideally none. Take a look over the longer period of time of a hypothetical patient and mood symptoms, let's say over the course from 2018 until 2022. So in this first example, this is what a patient's mood might look like who was taking medications. There still are some mood swings. This patient's medications are not perfect in that they are not preventing every high and low, but the swings from highs to lows are far less consequential compared to if we imagine a patient not taking any medications where there are extreme changes in mood from manias to depression and severe and debilitating psychosocial and interpersonal consequences as a result of those great mood swings. Well, what types of medications are there to treat bipolar disorder? In general, we lump them into 5 different categories. There are mood stabilizers, antipsychotic medications, antidepressant medications, anti-anxiety medications, and finally medications that can be helpful for initiating or maintaining sleep. One of the other challenges in treating patients who have bipolar disorder is that the illness commonly travels with other psychiatric and medical conditions, and these are called comorbid psychiatric conditions. So as an example, approximately 70% of patients who have bipolar disorder will also have an anxiety disorder. 56% of patients will have a substance use disorder, such as having struggles with alcohol or other addictive substances. A large percentage of patients will have post-traumatic stress disorder or PTSD. A sizable percentage will have social phobias, in which these patients have great trouble with social interactions and become quite anxious, self-conscious, and embarrassed in social situations. Another substantial percentage can suffer from obsessive compulsive disorder, OCD. And then a large number of patients who have bipolar disorder can suffer from medical disorders, hypertension, obesity, cardiac conditions. Given the complexity of bipolar illness in and of itself, and the fact that there are many other comorbid conditions, as I just showed you, it is not surprising that approximately 40% of patients took 3 or more medications, and those are just looking at psychiatric medications, and 18% of patients took 4 or more medications. And so it's quite common to have a patient who takes 1 or 2 mood stabilizers, plus an anti-anxiety medication, plus an antipsychotic. And again, those are just psychiatric medications. So if you look at these numbers, 58% of patients are taking at least 3 medications to treat their bipolar disorder. This is a table of the current FDA-approved medications for bipolar disorder in adults. And as you can see, the table is divided up on the top in pink, medications that are mood-stabilizing agents, and those include carbamazepine, divalproex, lamotrigine, or lithium. And then in the columns to the right are the current FDA indications. Below mood stabilizers are atypical antipsychotics, aripiprazole, acenapine, cariprazine, lumateperone, lorazepam, olanzapine, a combination drug of olanzapine plus fluoxetine, quetiapine, risperidone, and ziprasidone. As you can see from this table, there are many medications that are currently FDA approved to treat mania, all of the mood stabilizers and most of the atypical antipsychotics. In the second column over, however, what you see is that there are fewer medications that currently have FDA approval to treat bipolar depression. Those include cariprazine, lumateperone, olanzapine plus fluoxetine, and quetiapine. And finally, in the third column are drugs approved for maintenance or mood stabilization over time. These include lamotrigine, lithium, aripiprazole, and olanzapine. All of these medications, unfortunately, can cause side effects, and the most common being sedation, weight gain, GI side effects such as diarrhea or constipation. Medications, particularly the atypical antipsychotics, can cause metabolic risk, such as increases in blood glucose, diabetes, or increases in lipids and cholesterol. And finally, the atypical antipsychotics do put patients at risk for a movement disorder called tardive dyskinesia, tardive being late onset, dyskinesia meaning a movement disorder. These side effects occur in a smaller percentage of patients, but are important for patients to know about and important for providers to monitor. Well, what about antidepressants? This is a slide showing many of the common antidepressants that are used in the treatment of major depression. Do they work in the treatment of bipolar depression? These are the current FDA indications for antidepressants, and you can see they have a wide range of indications: depression, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, generalized anxiety disorder, social anxiety, premenstrual dysphoric disorder or PMDD, bulimia, chronic pain, and smoking cessation. But you don't see any FDA indications for bipolar depression. And that's because thus far, Currently, there are no antidepressants FDA approved in the treatment of bipolar disorder. We have no clear and compelling data that they are effective in bipolar depression. We do know that antidepressants can be associated with risks in the treatment of patients who have bipolar disorder, namely, they can potentially flip a patient into mania. They may cause mixed states in which patients suffer from both symptoms of depression and mania, and they may cause rapid cycling in which patients go very rapidly from a manic state to a depressed state. If patients do respond to an antidepressant, we don't know yet how long they should continue on the antidepressant. We do know that in patients who suffer from bipolar 1 disorder, they should never be given alone, that is, without a mood stabilizer such as lithium or a second-generation antipsychotic such as olanzapine or quetiapine, for example. There is some evidence in patients who suffer from bipolar 2 depression that antidepressants may in fact be helpful. It is important to educate patients regarding the risks and the symptoms of switching so that patients understand what symptoms they should be particularly keeping an eye on. And even with all of the above information, we do know that antidepressants are still widely prescribed to patients who suffer from bipolar depression, and in fact may be helpful in some patients with bipolar depression. Our difficulty is that we have a tough time right now knowing which patients may benefit from taking antidepressants and which patients they should be avoided in. As I said earlier, anxiety commonly co-occurs in patients who suffer from bipolar disorder, and anti-anxiety medications are often prescribed. These are examples of the two broad classes of anti-anxiety medications: benzodiazepines, which include medications like alprazolam, clonazepam, diazepam, lorazepam, oxazepam, and temazepam, again, are frequently prescribed. And there are a number of non-benzodiazepine anti-anxiety drugs, including the drug buspirone, hydroxyzine, gabapentin, propranolol, pregabalin, selective serotonin reuptake inhibitors, antidepressants, as well as serotonin norepinephrine reuptake inhibitors, SNRIs, can be widely prescribed for anxiety. You also see the medications that have an asterisk by them. Those are drugs that are frequently used in the treatment of anxiety, but are not FDA approved. Of course, sleep is very often a chronic problem for patients who suffer from bipolar disorder, and there are a number of FDA-approved medications for the treatment of insomnia. These broadly fall into the categories of melatonin receptor agonists, benzodiazepines, benzodiazepine receptor agonists, antihistamines, tricyclic antidepressants, orexin antagonists, and then a class of drugs that we do not prescribe for the treatment of insomnia now, barbiturates. With regard to melatonin receptor agonists, the brand name prescription drug is Ramelteon, marketed as Rosarum. Of course, over-the-counter melatonin is frequently used and readily available. I went over benzodiazepines in the previous slide. These are medications that are FDA approved for the treatment of insomnia, including astazolam, flurazepam, quazepam, temazepam, and triazolam. There are a number of benzodiazepine receptor agonists. These sometimes are referred to as Z drugs: zolpidem, zaloplan, and azopiclone, marketed as Ambien, Sonata, and Lunesta, respectively. Antihistamines are also FDA approved for the treatment of insomnia, which include diphenhydramine, which is Benadryl, and doxylamine. Tricyclic antidepressants can be sedating and therefore used in the treatment of insomnia. The one tricyclic antidepressant currently FDA approved for the treatment of insomnia is doxepin. And a newer class of drugs, the orexin antagonists. The orexin system is a wakefulness system, and so if you block a wakefulness system, the result is feeling sleepy, so the drugs suvorexant, marketed as Belsomra, lemborexant, marketed as Dayvigo, and daridorexant, marketed as QUVIVIQ, are the common drugs there. And then I mentioned barbiturates, which we do not prescribe for sleep, pentobarbital and secobarbital. Sleeping medications have pluses and minuses. They certainly can be quite helpful and work for patients, and sleep, we know, is an important mood stabilizer. The downsides of chronic use of sleep medications include issues of physical and psychological dependence, and in many ways, the psychological dependence issue I find more important. That is, patients feel they cannot sleep unless they take a medication. Some of these drugs can lead to long-term changes in sleep architecture. So, as you may be aware, when we go to sleep, we go through a series of stages 1, 2, 3, and 4, and also REM sleep. It's important that the structure of sleep remain intact, and some of these medications can decrease the time we're in deep stages of sleep or decrease the amount of time we are in REM sleep and increase the time in light stages of sleep. And we know that this overall is not good for patients' health. Some of these drugs are scheduled drugs or controlled substances, which can lead to other substance use issues. And we do know that medications like benzodiazepines in particular impart a higher risk of falls, particularly for patients who are older. There are a small percentage of patients who can take these medications and end up sleep eating or sleepwalking. And the typical story is a patient will go into the kitchen in the morning and find food all over the kitchen counter, and they have no memory of getting up, going into the kitchen, and eating food. And sleepwalking, sleep eating, sleep behaviors can potentially be dangerous. There are a number of medications that get used in an off-label manner in the treatment of all psychiatric conditions, and certainly in bipolar disorder. The definition of an off-label use is medications that may have some evidence that they work but do not have an official FDA indication. It is important to know that just because a medication is off-label doesn't mean it doesn't work. It simply hasn't gone through the very rigorous testing that the FDA demands. As an example, lithium does not have an official FDA indication in bipolar depression, but we have good evidence that in fact it works in bipolar depression. There is evidence lamotrigine is helpful in bipolar depression. It only has an FDA indication as a mood stabilizing agent, and we have evidence that gabapentin can be helpful in anxiety, but again, it has no official FDA indication for treating patients who have anxiety. There are many other medications that are used that have some studies supporting their efficacy, including antidepressants, as I mentioned before, small studies showing that pramipexole may be helpful in bipolar depression, small studies showing that N-acetylcysteine can be helpful, modafinil, and certain anti-inflammatory drugs, although these are of a much more experimental nature. Physicians may sometimes speak about rescue medications for patients. These are medications used in specific situations for a specific rescue effects. Commonly, for instance, quetiapine or olanzapine can be used when patients start to notice that they are sleeping less, becoming revved up or agitated, or if they're having increasing problems sleeping and the patient and the provider both know that a lack of sleep will precipitate a mood episode either into mania or into depression. Certain patients can notice that at different times of the year or under particularly stressful situations, they may become more irritable, and medications like aripiprazole or risperidone may be helpful for a limited amount of time in managing irritability. Anxiety, again, may be situational or particular to certain stresses in a patient's life, and benzodiazepines or hydroxyzine can be used with good effect in a limited way to help manage anxiety. It's also important for patients to realize that dosing of medications may change over time. Higher medication doses typically are needed during acute manic episodes, and patients can become hypermetabolic, in which they may be able to take much higher doses of medicines during a time of acute mania, and once the mania resolves, their need for such a dose greatly decreases. We see this, for instance, with lithium, in which lithium doses during an acute manic episode will produce a therapeutic blood level, but as the mania resolves, the blood levels increase gradually and doses need to decrease in a corresponding way. The goal of maintenance treatment generally is finding the lowest and most effective dose that provides the fewest side effects and the most mood stability. So in this example, to show you the changes in doses over time, a patient who has experienced mania needing 1,500 milligrams of lithium, as the mania resolves, the dose needs to come down to 1,200, and then finally a maintenance dose of 900 milligrams once the patient's mood has stabilized. So what are the take-home messages in this overview of medication treatment in bipolar disorder? The first is that communication with your prescriber is critical. Does this medication help? Are you getting side effects? If so, what can be done about them? Are there alternative medications? The second is that the more you know about a medication and its purpose in the treatment of bipolar disorder, the better. Knowledge and your active participation in treatment is what gives you the best chance of successful treatment.